Health Committee is being called to order at 10 after 1, and I'd like to ask Councilor Snell to lead us in the invocation.
Gracious Heavenly Father, thank you, Lord, for this beautiful winter day. And Lord, be with us, Lord, as we go through our committee meetings today. Be with our chairperson in the Health Committee as we doing now. Lord Jesus, we ask for wisdom, guidance, and understanding. Bless all our visitors that is with us today. And we ask your blessings on this meeting. Thank you, Lord. Amen.
Ms. Shelley, will you call the roll for us, please?
Janelle Fulbright.
Present.
Dick White.
Here.
Jack Baker.
Here.
Harley Buzzard.
Here.
Joe Byrd.
I need.
Julianne Coates. Here. Jody Fishinghawk. John Garvin. Hannah Glory Jordan. Present. Frankie Hargis. Present. Lee Keener.
On me.
Curtis Snell.
Here.
Janice Taylor. Here. David Thornton.
Nope.
Victoria Mesquith. David Walkingstick. Kara Cowan Watts.
All I need.
We do have a quorum.
Next is the approval of the minutes. I assume everybody's had time to look at them, and the chair will entertain a motion to approve.
Motion approved.
Second.
We have a motion and a second. All in favor of the minutes being approved, say aye.
Aye.
Any opposed? The minutes will stand approved. Next, we'll go right into reports, and we have the Claremore Indian Hospital and Mr. George Valuers.
Good afternoon. Dr. Stephen Sanders, who's been our acting clinical director, is going to be phasing back out, going back to Pawnee over the next month. We have advertised for a clinical director and hope to get that filled by the time he leaves. We're still actively recruiting internal med docs and emergency room physicians. Outpatient visits are slightly up. Our chiropractic service, we've actually going really well. We're going to try to expand that to 2 days a week. That was kind of a pilot program from area office. They offered us one for 1 day a week, and it has really taken off. He averages about 35 to 40 patients a day. So we're going to expand it. We have a waiting list generated. So we're going to try to expand that to 2 days a week. If you haven't been by the hospital, we have the slab poured for the MRI. Engineering tells me that they should be moving the crane in, delivering the modular building, and then dropping the MRI through the roof. We are scheduled to, they're scheduled to have it in just after the 1st of April and start live training April the 15th. We just finished training on a barcode medication administration on the inpatient side, using barcodes on the pre-printed bracelets to cut down on any type of medication errors, misadministration, things like that. We just finished that last Friday. That's being kicked off today. Any questions?
Councilor Keener?
Thank you, Madam Chair. George, do you mind going over the that third point about the revenue decrease? 14%.
Right now, we have our coders had been dual coding using the new ICD-10 and ICD-9. We are going to be required to go to ICD-10 in October. We have asked them to stop coding in both and go back to just coding in ICD-9, which is the current practice, current standard. So we'll go back to that, get caught up, and I think there was a misunderstanding on our medical records department. Area had asked that they dual code, maybe 5 or 10 a week to see how it works. They took off and they were dual coding every claim that came through. So we'll back off and get caught up. That's where our shortfall is.
And the home office understands that?
Yes. Oh, yes.
Thank you. Thank you, Madam Chair.
Counselor Buzzard?
Yes, thank you, Madam Chair. I want to say that I'm glad to be back to the committee meetings and attend the tribal council meeting tonight. I'd missed doing this, but I don't miss staying home and looking at the four walls for a month, so but it's good to be back. I do have a question for Mr. Valier. On the second page, George, I know that you have told us how to read this before, but quickly, would you tell us what each of these numbers mean? I'll write them down this time so I'll know.
On the contract health,
Yes, on the activities.
the funded, for the month of January, we funded 405 cases at an estimated $596,000.
Now, does that include all patients? That's the Cherokee report here.
No. Then you keep going out to the right there where it says number of Cherokee,
Okay,
218 out of those 405 were Cherokee.
okay, got it.
We denied 155 cases
Okay,
at that estimated dollar amount, and 68 of those were Cherokees.
Cherokee, okay,
And then the same for the deferred. We deferred 489 at that estimated dollar amount, and 342 of those were Cherokees. And the CIH clinics, those are usually referrals that come in from outside clinics
yes,
that don't go through the contract health system, because that's a service that we offer there at the hospital, and we just reroute those.
okay, well, that's getting straight again. I have lots of memory, I guess.
That's okay. That's okay.
Thank you for explaining that again. Thank you, Madam Chair.
Counselor Watts?
Thank you, Madam Chair. Thank you, George, for being here. Congratulations on getting the slab poured on the MRI. Does that mean we're still on the original schedule, I think? Is that
Actually, I think we got pushed backwards a couple of weeks with the icy weather.
so that's probably May is what we're looking at?
No, we're looking at the middle of April. It was actually supposed to be the end of March, I believe.
Okay. Very good. And then how's the Affordable Care Act outreach going?
From what I'm told, we have 7 counselors to assist patients, and last time I checked, we have gone through and helped, got online with several patients, but have enrolled none. Nobody's interested in enrolling. They
Okay.
want the number for the exemption.
Okay. I thank you for that. And then, just to make sure I understand what you and Councilor Buzzard were discussing, so it's like out of the funded 405, there's 218 of those are Cherokee Nation citizens. Or Cherokee?
Sure.
So
We
it
don't-
could be United Kituah Band or Eastern Band?
We don't distinguish between citizens or what other definitions
So
you
they
guys
may have
have.
CDIBs, but not citizenship?
Yes. If they're registered as Cherokees, that's what's counted.
Okay, and it also doesn't differentiate, I guess if they're funded, for example, they would be in the jurisdiction, but if they're denied, that 68 could be out of jurisdiction, that may be the reason for the denial, is that right?
Could be.
Now, on the internal clinics for the 115 cases, those numbers are not included in all in the funded, denied,
No.
or deferred, right? That's just an opportunity where there was initial contract health referral, but you, after review, you could find out you could bring them inside. Okay, very good. Thank you, Madam Chair. Thank you, George.
Any other questions? Yes.
So, George, I think what I'm hearing is on the 218 that are Cherokee of some sort,
Yes.
then that's turned to Brett Hayes.
Yes, ma'am.
And then Brett breaks those down into the Cherokees that are covered under our contract health.
Yes, ma'am. That's what I understand, yes.
Okay, so we can continue with your report with Red Hayes, is that correct?
That's-
He'll
yes.
have a further breakdown. He takes a second column and starts breaking it down from there.
Yes, that's what he picks up from our system and goes from there.
Okay, all right, thank you.
You're welcome.
All right, thank you for that good report.
Thank you.
Next is Mrs. Connie Davis with Cherokee Nation Health Services.
Good afternoon.
Afternoon.
To highlight some things from the report this month, Cherokee Nation EMS achieved their fourth successful survey from the Commission on Accreditation of Ambulance Services, or CAS, which puts them in the top 1% of EMS services across the nation. There are 10 main sections and 51 subsections in the CAS standards, which include organization, interagency relations, management, financial management, community relations, human resources, clinical standards, staff operations, risk, equipment, facilities, and 911 communications center. After careful reviews, Cherokee Nation EMS was awarded a perfect score of 3 in each section, which translates out to a gold medal for EMS. So Dr. Randy Underwood, Jimmy Summerlin, and Tracy Glory are to be commended yet again for an outstanding job in running our EMS service.
I'm very proud of that.
Another major accomplishment in January was the Bonita Clinic, Three Rivers, and Salisal clinics were recognized as and received Certified Healthy Business Awards. And these are initiatives where they've implemented measures to promote healthy environments and initiatives within their work environments. So they're to be commended as well. On Friday, February 7th, we held our first annual Heart of the Nation luncheon here in Tahlequah. The luncheon was organized to promote awareness and education for the fight against heart disease in conjunction with the American Heart Association Go Red for Women Day. And something that I learned was that, a lot of us think that breast cancer is one of the major killers of Native Americans, but actually cardiovascular disease leads in killing Native American women. So we need to bring awareness to that. Dr. George Comia, who has been a longtime friend to the Cherokee Nation, he spoke along with some of his staff and also had a fantastic speaker, Marcella Morton. She's a Native American who shared a story about her commitment to a friend who died at a young age and her story of weight loss and changing her whole lifestyle. And she actually competed in a Boston Marathon. It's quite a story. I'd love for her to come speak to this group at some time. We're still busy despite the weather. In the month of January, Wilma P. Mankiller saw 10,117 patients. Redbird Smith, 10,308. Salina, 8,433. Jay, 7,492. Nowata, 4,786. Muskogee, 14,664. Bartlesville, 2,072. Bonita, 6,266. And Cherokee Nation Hastings Hospital, 29,795. To highlight, the emergency room saw 6,208 patients and had a left without being seen rate of 6%. But I know in conversation this last week, we had 2 nights that nobody left without being seen. So we're making huge progress on making sure nobody leaves. We have to grab them by the leg. So don't leave. Our surgery department performed 364 cases. Another thing I wanted to highlight this month is we are recruiting and signed contracts on 2 of the residents that we have in our service. Amanda Bighorse signed a contract. She'll start with us in July. And Dr. Dustin Beck, who has been noted as being the top of his class from OSU, will start in August here. So we're getting 2 great physicians from the OSU residency here. And another thing, I know behavioral health has been on our radar here lately. We've signed a contract with the psychiatrist to begin in September, so we're really glad to be getting that support staff. Behavioral health saw 1,277 patients in the month of January. Jack Brown has 21 patients, 12 males, 9 females, and 16 waiting. And our elder care PACE program has 130 patients, and I think that may be a record number for our elder care program as well. Oh, Counselor Watts asked about the ACA, and just to maybe highlight that, we've educated 284 members or patients on the Affordable Care Act. We've helped people,
How many did you say I could
284.
terminate?
Completed 41 applications, enrolled 13, and given out 54 exemption forms. And there's 2 other things I want to highlight. One, we've been talking for, I guess, 2 years, as long as I've been here, and even before that, about the great need for a new electronic health record. And I'm excited to let you know that we are in the process, with your support, of making a selection. We can only provide limited information because of contractual agreements. We can meet with you privately. There's some non-disclosures in that. But Mitch Thornbrew, who oversees a lot of our health IT, would like to come up and give you some highlights of things that will be provided through that.
Thank you, Connie. Good afternoon. As Connie stated, we've gone through this process for a few years where we've tried to identify all the needs of the health system, and we've really identified some serious issues with our current electronic health record. Not only have we identified those, we've done as many workarounds as we can, but ultimately we're unable to work with the vendor, IHS, to resolve all of those to our satisfaction. So that led us to look outside of IHS of what we could do. And the reason is those issues that include clinical documentation, patient safety, regulatory compliance, all those issues affect our entire health system. And ultimately, they're going to limit our ability to improve access to care and quality of care with the rest of the country that's going through all the changes with the Affordable Care Act and all the regulatory compliance that's been ramped up. So health services involved about 150 staff from all aspects of the health system. That included physicians, nurses, pharmacists, to help us evaluate and select that new EHR, and that was about a year-long process. With that, that's kind of the process we went through to select the new EHR. But because of some of the confidentiality provisions within the contract, we can't talk about many of those details publicly. But I'd be glad to answer any questions you have or meet afterwards, and I'll provide my contact information to everybody here to make sure that all your questions are answered.
Anybody have any questions?
Thank you.
Counselor Buzzer, did you have something you wanted to
Yeah,
ask
a couple
Connie?
things I just wanted to, got 3 things I want to talk about. One is behavioral health. I've had some comments, I guess, from people, and they feel like we don't have enough of those people to take care of our people that need behavioral health. And I'm wondering, do you foresee in the future of adding staff to that particular department for behavioral health? Because I know there's a big need out there for it.
There is a big need. And what we're doing right now is doing an evaluation of the productivity with the staff that we have. And then this is a good time that we're doing that. It takes us about 3 months to really study and get an idea. And then the weather, these months are not really a good evaluation time, if you will, because of the amount of days we've been closed. So we want to give a fair opportunity to the clinicians and make sure we've got a good tool to measure what they're doing, and then that'll come a long time with the budget and see what we can afford to do.
And I suppose every clinic has a person in the position now?
Well, Bartlesville doesn't have
Doesn't have one.
anything, but we do have plans, I believe, in Oshaleta.
The other one I just saw in the report, we're going over with the Red Fern Group on the design of the hospital. And recently I've been in, say, ortho at the, and what we got up there, and I've realized that, I'm not an architect, but when I walked into the building, it wasn't designed to take care of ortho patients. And one thing, the hallways are just too narrow. You can't get two wheelchairs up and down the hallways. And my question is, and my comment is have you invited people from that particular department to go over these plans like you did the J Clinic and Oshaleta Clinic? Because I
Yeah.
felt like those are really important to have the staff come in and give their input.
We do too, and yes, they have been involved.
On the people that enroll in the Affordable Care Act, what is their reasons for not enrolling? I think we only got 13 enrolled.
I
They
think
feel like they're getting,
they feel like they get the services they need for the most part, and I don't know that they fully appreciate the need for us to be able to bill and collect a lot of times. I heard
and I'm
some
wondering
discussion
if we're saying
between
that enough. That's-
Elton Sunday and Connie Donovan, who spearheads that group, and it's becoming a bit of a competition on who can get someone enrolled for the least amount, and someone actually was enrolled for 2 cents a month, and I think we aren't telling those stories enough. I mean, but we're hearing it. It's a new process for everybody. So I think the more we publicize that and say 2 cents a month, you can get this coverage, and we can add more services. We can add behavioral health staff or, more providers or whatever it is we need.
The last question I have is, on the collection of VA benefits, are we doing any of that? I didn't see any.
We are working with the VA to get the terms of a contract worked out.
Okay, good. Thank you. Thank you, Madam Chair.
Counselor Walkenstick?
Hi. I was at Hastings a few weeks ago, and anyways, I seen a lot of handicapped people and elders walking a large distance because they had to park in the back of the parking lot there at Hastings. And, at the Hard Rock, we have valet parking. And I was wondering if we could have valet parking at our clinics and our hospitals to provide customer service for our elders and our handicapped only. I think that'd be a good service for our people. And I didn't know what the process would be. I know it would be, creating extra jobs, but I don't know. What are your thoughts on that?
I think we're thinking along the same lines. We actually had that discussion with the hospital design meeting earlier last week, and we would be in complete support of that if we could afford it. We'd obviously have to talk to our risk management group because there'd probably be some liability of an employee assuming responsibility for someone else's car, but we would love to do an evaluation and see if we could offer that service.
I think the valuation is watching the parking lot, watching elders. I mean, that's
Oh,
the
yeah.
valuation.
And we have carts to pick patients up and maybe just utilizing them more as well until we can do a true valet service.
It'd be a great customer service. Thank you, Connie.
I agree.
Thank you, Chair.
We have any more questions?
Thank you. So on the Affordable Care Act, are we going to see if those folks would actually tell their story in the Cherokee Phoenix? Consider that?
We could.
I think that would be helpful. I do
Okay.
think because at least in Oklahoma, there's a lot of anti-information, but there's not necessarily a lot of affirmative information where there's positive opportunities.
No, that's a great idea.
Especially, I assume on budget projections, we're relying on people probably to sign up for revenue, potentially, aren't
Well, we're trying to be proactive. That's why we're at community meetings. We're working with the chief's office on some publicity campaigns to encourage, participation in the ACA. So we're trying to stay ahead of it and promote it.
we? Okay. On a, how are we doing on dental staffing? And I think Dr. Jones is here, so he may want to answer that. 'cause
I'm glad
getting-
you mentioned that. So if you don't mind, can I ask him to come up and?
Yes, I have additional questions, but that can be addressed first,
Okay,
if the chair doesn't mind.
all right. Dr. Jones?
I've gotten feedback that specifically that we're short-staffed, and so that's where I'm trying to figure out what's going on.
Connie has asked me to kind of give you a summary of some of the things going on in dental, and when I do that, it's kind of difficult because there's so much that we don't have enough time that I would really like to tell you all about our program. But I'm going to try to condense it down to kind of the highlights and then go over some statistics that we have available, so help to understand. And if there's anybody that wants to meet with us privately afterwards or in small groups, be glad to do that. I brought along Dr. Speed,
Dr.
who
Jones?
heads up. Yep.
Is this, I know you had a presentation. Why don't we, I would suggest that we go ahead and take the rest of the health questions and then let you do your presentation last. Would that be okay?
That'd be fine, yeah,
Because
whatever
I think-
pleases the council.
I think you had several people that came with you too, is that right?
Yeah, I'm just going to present, and they're here to answer questions afterwards if anybody has any questions afterwards, so.
Counselor Watts, you want to go ahead and answer the rest
Yeah,
of your
so-
questions?
Thank you.
Sure.
So I think this may be Connie back on.
Okay.
So you kind of addressed, because Councilman Buzzard also asked about behavioral health. So tell me again, I don't think I heard, when do we expect, because of the delays in weather, that we're going to move forward with maybe a different plan? Is that something you're going to present to us here? Or how will we learn about changes in behavioral health?
Well, we developed a scorecard like we have with the primary care. We've done it with pediatrics. We are working on one with the surgeons. We've done it with physical therapy. We've also developed one with behavioral health. And so now what we're doing is allowing them to make sure they feel like it's a fair and accurate tool to measure their productivity. It includes quality measures because we don't want them thinking we're just wanting them to slam patients through the process. We want it to be a quality service. So we've measured 1 month. We're going to measure about 3 months and then go back, talk to those providers, and if they feel like this is a fair and accurate representation of their workload, then we'll make a determination on the needs for additional staff, if there are in fact needs.
Okay, well, this is exciting, so thank you very much. Then, I guess my last questions before we can move on to probably old business number 1, but I do have questions about the agenda too. I failed to get a few out. In your report, the Cherokee Nation Contract Health Service, which are those folks already automatically covered inpatient, outpatient, Cherokee Nation, that is a 98, I want to make sure I'm reading it right, 98.35% approval rate for Cherokee Nation Contract Health. Does that sound about right, Britt? But, so in Cherokee Nation, and this is not the 5% set aside. So then when you start getting to that, like for example, in this January 2014, there's 4 that have been denied and there's 103 that are pending. And I was trying to figure out, I still haven't got a good grasp on a couple of things. First of all, the follow-up on pending. So the assumption right now is that pending will eventually always be took care of. So from month to month, I don't know if the last month's pending was addressed or not. Like, I think so there could potentially be people lost in the numbers is what I'm trying to get a hold of when I look at it.
I think what the counselor had asked, and please correct me if I'm wrong.
No, please, that's
that
what-
she had wanted, and I do recall this, like next month to report on, of the 103 that are pending, did we go ahead and approve those, or are they still pending?
Those may pend for some period of time just because of health insurance, say Medicare has to pay.
We talked about documentation last time, I
Right,
think.
patients have to provide some level of paperwork sometimes, especially on a hospital, hospitalization and things like that. So there's,
Trying to think of a way to report that out so we have a better understanding of the
Yeah.
pending population.
And this is done by hand, it's manually, another thing, a
There is
limitation. of our
nothing
system.
easy about this contract health 5%.
No.
I understand that. I mean,
Yeah.
you two are tortured with my emails daily from constituents.
So,
I don't know if there's a way
And
to
that's
do
what I've
that.
tried to wrap my head around how to present it to them. It's just, I don't know.
Okay.
uh,
Because it's not funny for us up in Rogers and Tulsa County. This is real health issues, people
Oh, yeah.
life or death. So I guess some people find it funny, but I know we don't.
Yeah.
So,
no, because if there's 103 out of 300 here, you could multiply that probably by 1,000 in this area because of the number of Cherokees in this area that have pending claims for the same reasons. You know, it's not a unique problem or challenge to this, to the Claremore area to have these kinds. Needed
Well,
additional
with the-
documentation.
yeah, with the Cherokee Nation numbers though, we're not getting that kind of feedback. With the 97-98% approval rate, it's a much smaller population if there's pending, I guess, is my take when I read the reports.
Yeah, those are reports that are, you know, maybe we need to rethink how we present the other reports, because that's one that historically, since 2004 is what we, you know, that's just, we've always had, you run that report and here's what it says, and maybe, you know, I talked about looking at that different also, but that's,
When people ask, and I want to make sure that
it's kind
I'm
of comparing
communicating it
apples to
accurately.
oranges to some extent.
Okay.
You know, so there's still fruit, but there's all conduct health, it's just a different
Okay.
presentation.
And we also talked about the report, it's our page 22, but it's the distribution by communities. Is that now being done by physical addresses, or is that, this part is still physical addresses for their home residential address?
Correct.
But there was one report that was being done by facility of source.
Well, there's the address they reside, and then there's, you know, if a person lives in Chelsea, and next thing you know, they're seeing, if they need a doctor, they're gonna be in the need a clinic. If they live in, that's a good example, I mean.
Okay, so when, there's like 87 reported here on the January 2014 community report for Veneta. But there's also Chelsea reported.
Right.
So I assume this is by residents.
It is by residents.
Okay,
So when it comes to on the financial side, it's gonna go through the clinic.
right.
Be filtered through that clinic.
And we don't have that report anymore, that's no
Right.
longer, okay. I just want to make sure that I didn't assume something. Okay.
So some of those residences lose the ability to track that once it's
So-
paid,
So we still know that we need to figure out the pending. I think there's an issue
Yes.
that we can see, and I appreciate that you're manually having to do that.
Yes.
So, but if we could get there in the next few months, that would be great.
And I think in the near future with the changing stuff at Program CHS,
So in general, could you give us an example again of like the 4 that are denied, what those type of procedures would be?
I mean, I've seen some that were denied. It was a pre-op for surgery that's outside of our scope. Bariatric surgery. But if somebody wants to do that's a good example of one that, you know, it's just maybe an EKG, it's maybe a sleep study that's kind of improved because it's related to a procedure, we're not going to out of our scope. Other things are,
So-
if it's an ER call-in, for instance, and next thing I know, I'm in ER, and I have gastritis. I don't know if we're gonna pay for the stomach problem that some lives in, say, it didn't pay for it. Hey, they could have gone, we do that, we can health walk. That visit could have gone to Hastings, we want them to go there.
Okay. That's helpful, because people ask, and I don't know how to answer that, so that's very helpful. Thank you very much, both for your time. Thank you, Madam Chair.
Thank you. Are you through, Connie? You want to go on and call on Dr. Jones to go ahead with his presentation now? Oh, I'm sorry, Counselor Lay, I skipped you.
I didn't want them to get into the presentation and me have a question.
Okay, go
and
right
Brett
ahead.
and Connie leave the room. Thank you. I'm going to ask this question. Will the electronic health records aid and assist you to produce any report that any of these counselors ask of you? I mean, are you gonna be able to punch a button and give us these reports that you're being questioned about today?
I think so.
I think a lot, I mean.
Well, I don't wanna hear I think so.
Well, I don't know what you're gonna
wanna
ask
see it.
for. So that's why I hesitate, because I don't know what you're gonna ask for, but there's just so many little things that, like this, that should be able to be produced, that will be able to be
By
produced.
hand, I can imagine how difficult this is.
Oh.
Well, and to be honest, we're gonna have input into the designing of
Okay,
reports. So
that's what I wanted to hear.
We can
Yeah.
kind of map a road map if we want.
So, is it in design or designed already, or?
Some parts are in design and some parts up. Correct me if
We
some
can
parts
talk
are-
about that
some parts are somewhat
confidential,
designed.
confidential.
Some parts aren't, there's not a lot of concrete health packages.
Okay,
So
if
there's
I'm-
gonna have to be some building of it.
If I'm overstepping a confidentiality agreement, I'll stop here. Okay, I just wanted to make sure that electronic health records is gonna have to do a lot of things, in my opinion. And y'all have heard me squawk about it. So I wanna see some shaking of the head, yes, that this will happen.
Everybody squawks. We squawk, the docs squawk.
Thank you. And the issue at Hastings, you know, of course, I know we had a lot of snow and ice. Do those carts run on a regular basis to pick up our patients? I wonder,
They don't run on a regular basis.
why not?
I don't know that we have a staff to run them on a regular basis.
Okay.
Which guys, they don't run on the snow very well at all.
Well, and that's gonna be something that I can understand. I've just got through wading through 1.5 inches of ice and 6 inches of snow on top of it. So the only thing that went through that was my feed truck past week or so. But if we have, it's a long way from the parking lot, as David has said, to the entryway.
And it's sloped.
And it slopes, and maybe we ought to think about running a cart.
We have been,
That's up to y'all, but maybe you should think
absolutely.
about it. And the ACA Act, have you all identified any programs, health insurance available, that would be available to our citizens that you like more than some of the other programs?
There are so many.
I know, but have you found some that you like?
I would not even speak to that right now.
Shouldn't we be looking for some that fits us, that we like?
It's all based on individual income,
I understand.
so there are so many variables.
But it's gonna help us, help you make ends meet. Help us make ends
Understand.
meet. So we need to probably look at that. Thank you. Thank you, Madam Chair.
Counselor Fishing Hawk?
I was about to say on electronic health records, well, better imagine every hypothetical question we're gonna ask to put a field in there, Connie.
Yep.
I've messed with health, I was about to say, I've messed with electronic health records, and ain't nothing like what we're gonna ask.
Thank you.
Thank you, Connie.
Speaker Jordan?
You know, Connie, I was thinking, the whole first row at Hastings is designated handicap, where you have to have the little thing that you hang off your mirror. Maybe we should designate the second row for elderly that don't have one of those, but they're still elderly. If we could put some signage up to say that, you know, we'd like to designate that second row for our elders. And, because the rest of us, it's not gonna hurt us to walk from the back row. I mean, I pull into that second row as much as I can, but if I saw a sign that said this is for our elders, I would naturally go to the third, fourth, or higher. And it really wouldn't hurt a lot of us to walk a little further and come back. I mean, that's good exercise, really. You might think about that and see how it would work on the honor system to let the elders use that second row.
Mr. Harrell is here, and I'm sure he'll take that under consideration.
And that might get some of the rest of them off the back row, so to speak. I sit on the back row at church, I guess I can park on the back row at the, so, but just a thought. Having used it, and I use it every month, you know, I have people say, well, none of us use the clinical or the hospital system. Hey, I was born there and I use it I've used it probably every month of my life. And so we have come so far. I say this more often than probably not as often as I should, but we have come so far from where we were many, many years ago. It's easy for people to quarterback our health situation. It's kind of like the Monday morning quarterback after the Saturday game. After you know the outcome, it's easy for you to be the coach and the quarterback. I wish they had been here 40 years ago and they see how far we have come in that 40 years. I just think, you know, people say, well, I hate Obamacare. I kind of think we might have been Obamacare for the last 40 years. And when Obamacare goes into force, we're going to shine because we have already worked out all of our bugs. There's always going to be something you can change and make better, but we've come a long ways.
I completely agree.
I was probably one of the last patients in Hastings Hospital when it was up where the college is now. And that would have been, I was trying to think.
80.
Yeah, because I'd had a car wreck, and I was in the old Hastings Hospital just before they went to our new setting.
Probably 83 or 84 because I graduated high school and worked as a nurse aide there.
Yeah, it was later than
in
the
83.
70s. I want to say because I was in there in the early 80s, and it was still. I can still remember being in the emergency room. It's just so much better than we've had it before. So I want to thank you for that. But
Patient wards with 4 and 5 patients in them, and now we'll have all private rooms in our new hospital. So that is a long ways to come.
And I remember when my mother was there, and it was a ward.
It was.
There was at least 6 other people in the room with you. It's so much better than what we. In fact, we're ahead of a lot of hospitals because we do have private rooms up in the hospital setting. Thank you.
Counselor.
Thank you, Madam Chair. I have a comment in that regard, but just a little different scenario to help us keep thinking along the lines of possibly entertaining valet service. I took care of my mother for 3 years before she passed away, and in those 3 years, she either had a walker or a wheelchair. And as the person that drove everywhere, did everything, it was sometimes a real hardship for me to pull in front of the hospital, wherever it was, get her out, get her equipment out. If it's wintry, cold, get her inside the door, get back in my car, park 10 miles away, walk back while she's sitting there by herself waiting on me. That's another scenario that doesn't help. You know, it's just an idea. Thank you. Thank you.
Okay, I guess we're ready for Dr. Jones's report.
All right. Along the lines of the electronic health record that they're working on, one of the benefits that they didn't talk about was the integration of our dental electronic record into that. Right now with RPMS, that integration is very, very poor at best. We've even turned off the interface, and only the demographic information comes across because it messes up so many things inside our record that causes rework and rework and rework. So it'll be a good thing for us too. We're looking forward to it, to try to get those interfaces started back. So, just a side note there. On the Affordable Health Care Act, just one of the things to touch base for us in dental, there's a small portion of that, but not a large portion. But our patient base that has third party is so small, it's down around 25%. So we're looking at one of every 4th patient comes in, trying to maximize those revenues that we can get off those patients that have third party. So as I show some of these graphs I'm going to show you here in just a minute, just keep that in mind. We're dealing with 25% of our patient base having some type of third party. So we're doing a good job at maximizing that right now. There's a lot of things that I can say about our program. I can go back to when I first came in and start from there, but I think due to time, I'm just going to kind of hit the highlights of what we're doing and what we're currently working on. One of the things that I noticed when I came in, there was no no connection between the clinics. Every clinic seemed to run independently. There's not a vision or a plan for how to treat our patients. And as a result, you had a lot of patients jumping across from one clinic to another. They'd go to Muskogee to get one thing, they'd go over here to Salina to get another thing, and there was just no continuity there at all. So we've kind of aligned everybody, moved them in the same direction, condensed our scope of care down to what we really need to be doing, prevention, different levels of restorative. You've asked me about the Crown program a lot. The Crown program is actually a level above that, so we need to get the other things and doing them right first. Then the Crown program comes after that. There's been some other emails that I've read recently about even more higher level work that people are wanting us to do. We've got to do a good job at what we're supposed to be doing first before we move up to those higher levels. Not to say we can't do it, but we need to be able to do it in a way that we can sustain it and not break our budgets. So anyway, I'm just going to move down through some of the stuff that we've worked on and been successful at this last year. This is the first time we've had a dental budget. So we've got a budget specifically just for dental services, and that way we're able to control our cost a little bit, shop our supplies a little bit, put them all under one umbrella so we can negotiate better pricing. Even our contracts, we've been able to negotiate some better contracts because of that. So in another year's time, hopefully we'll be able to put a profit and loss statement together and actually show expenses versus revenue. So we're working toward that. Our electronic record will allow us to do it if it's accurate. But again, we had to figure out that there was some stuff going back and forth that was messing everything up. So we're working on that and still working toward getting that done. We've worked on a new registration process. So if you're a patient and you come in and you've been to our clinic before, you can bypass central registration, go straight to our clinic, and our receptionist will be the one that takes your information. So that speeds up the lines. Speeds up your ability to get in so you're not running behind when you get to your appointment. Increases efficiency. So we're working on that. If you're a new patient, you still have to go through that central registration process, and we've accounted for that, and we usually have the patients come a little early so we can stay on time. Across the system, we've implemented a private practice model away from the IHS model. It has to do with customer service, how we treat our patients, how our staff is, the model our staff is put in, on how many doctors are in a clinic and how many assistants they have. So those things have all changed, and we're still working on those daily, working on the implementation of customer service for sure. And if you use our dental clinics, then you should be noticing those differences. We have a lot more compliments now than we have complaints. For the first time in January, we actually had more compliments where people left their appointment, went and found somebody and wrote it down, sent it to us. Then we had complaints, which the complaints have slowly fallen off since we started putting these models in place. So hopefully your constituents are seeing that. We've developed and started really working on our community dentistry part, and that's why I have Dr. Speed here today with us. She is the one kind of heading that up. Under community dentistry, you have your schools. We have integration into some of our social services that we do, like Jack Brown, Elder Care, those type, Job Corps. Those entities were not being introduced into our dental program. They were left to fend for themselves. So we've integrated that in, and those patients now have direct access into our program. So talk to people that are head of those programs. You can get their input. I won't talk for them, but they seem to be pretty happy with us so far. The diabetic program is a huge deal for us. It's a huge deal for Cherokee Nation, and this is the first time that dental has been a measure on that for the grant. I don't think they've ever felt like dental was consistent enough to be able to be a measure, so they've added that this year, and we've taken our numbers from 36% up to 55% across our system, even with clinics that don't have dental services, like Nowata and Bartlesville. Those patients count against us, so we've started taking our portable equipment out and doing diabetic screenings in those clinics. That's something that we just started doing recently, so those numbers should continue to rise. We worked with Contract Health to start being able to document which ones we're using 5% money on, which ones we're using the Contract Health money that comes from IHS on, which ones going under the PROS program. So we're starting to get those statistics to come in now and be able to see which money that those patients are being treated with and how many patients are denied services. So that's one of the reasons that we raised the poverty level on that PROS program, is because we found out that as we were tracking that, we had people that were being denied for that reason, and we weren't spending all the money that we had in that pot. So we raised that eligibility requirement up so more people would be eligible for that service. So we've had very, very, very few denials now. It's usually by where they live and whether they're not in the jurisdiction or not. So, does anybody have any questions on any of that? I'm traveling pretty fast through this, so.
Counselor Watts?
Thank you. Thank you, Dr. Jones. So I understand the Crowns are still a wait and see after we've done basic. You're revamping or reorganizing and make sure we're doing basics well.
Yes.
So then will come an announcement on Crowns.
We're probably within 30 to 60 days having it done.
Okay.
The program is really close to being finished. We're looking at the financial part of it, because it needs to be a neutral impact on the budget and how we integrate that in. Because once we put it in place, we don't want to have a situation where I'm back up here asking for money because we can't sustain our budgets. And as you can imagine, that number could get extremely high really quick. We did a study in our system just to see how many patients in this last short period of time we could have treated under the eligibility requirements. And it would have cost us about $500,000, maybe more, for our budget in that short amount of time. So we've come up with a plan. We're implementing it and testing it to see how it's going to work from a financial standpoint to make sure we can sustain it. We're going to cut the price. Before, I think the Crown program was costing $200. It's going to be $100, so we're going to cut the fee in half if we can sustain it at that rate. So that's the question right now. Making sure that we have proper processes in place at each clinic to handle that, because we're not accustomed to taking money for anything. So we've got to set up the processes to ensure that we do it accurately and we're accountable for that, and don't give the opportunity for that to be abused in any way.
On a side note, were we able to donate that equipment to Claremore Indian Hospital that I'd requested? There was some, I think it was around Crowns that were excess equipment.
I'm not aware of that.
I will resend that email. I thought I got a response. Okay, so
We
then,
still have our equipment, if that's what you're talking about, the CEREC equipment?
there was some kind of equipment that was laying dormant, and so somehow folks knew about it. There was a request. I thought at least Connie and I talked about it, so maybe. Okay, so dentures. So under the 5%, dentures are supposed to be available. And I think right now, when we've asked about this, Rogers and Tulsa County is just told to go somewhere else. So what I also heard in your report was that we're going to have consistently the same services at each location for Cherokee Nation. So people aren't having to service shop and bounce around the nation. So that's kind of how I describe it. So right now, we don't have a facility in Rogers County or Tulsa County except for Claremore Indian Hospital. And it's just said they have to go to one of our facilities.
Yes, they do. They have to access that program through one of our facilities, because they do have to have an exam, and they have to have, not every case is exactly the same, and every case has to be treatment plan, so to speak, from one of our dentists in one of our facilities.
Okay, so we talked about having a brochure or flyer or something. Was that ever provided to Claremore Indian Hospital?
Yes, it was, electronically, and I got an email back thanking us for sending it to them, but.
Okay, but I think we had to provide copies because you don't have a budget for copies. Is that right, George? So can we provide physical copies to them? Otherwise, our folks have no access to this program is my concern.
I gave it to them electronically where it can be printed off, so I mean, I guess.
But if they have no budget, yeah, to print and no ink money, no paper money, then that doesn't go very far for them.
I don't have a
And-
budget for publications either in dental, so I mean, I guess that would be a question for our budget people.
Okay, I would appreciate it. And then, can you talk to me about level of service? So you talked about like the service has changed. So if I'm a user and I go in, am I going in to, like, every 6 months and it's a full cleaning and and then once, I guess, once a year, once every 2 years, you get x-rays, or how does that work? What does that look like that
We can-
people should expect?
We can obviously get into all that if you want to. I can give you a highlight of it. Normally, you
The
would come
highlight's
in.
fine.
You would come in for an exam. In the past, I think after you've gotten your exam, they scheduled you back, or you were told to call back to get your work done, and then from there it was on you. And so after your work's done, you were told to get back with us in a year's time and get back in for another checkup. Now we're currently switching over to, again, the private practice model. We're increasing our hygiene program, which would allow us to do a recall system. Now, what you're talking about is a recall system where you go in and you have your exam, you have your work completed, and then you're brought back in at 6 months or a year for another checkup and cleaning. And then that's done every time, and we track that so that we can take as much of that burden off of you and put it on us to track and call and remind you when it's time for you to do that.
Okay, that's very helpful. That's what I needed. Thank you.
We're not there yet. We're getting close.
Okay.
But we're implementing those. As a matter of fact, we have a meeting this week with all of our hygiene staff to implement those protocols. So we're moving toward getting that going. It's not as simple as just saying, hey, let's do it. We've got to make the room and teach everybody how to schedule correctly, how to be more efficient with their schedule, because as this grows, it's going to exponentially grow as people start using our service more and more.
Okay, and I guess we didn't answer the staffing question. So are we fully staffed, or is there concerns? Because I think there's someone about to have a baby like at Jay, and that they're the only dental provider, I guess. So do we have backup for that?
No, we have another dentist coming to Jay. We have doctors within our system that are doing PRN work, which means they do their 40 hours wherever their normal clinic is, and rather than going out to private practice and working that 5th day, they have started to work within our system, which in the long run will help us because they won't be recruited away from us. So, but yes, we are aware of the FMLA situations coming up, and we're making plans to accommodate our clinics for that.
Very good. Thank you very much. I appreciate it. Thank you, Madam Chair.
Councilor Byrd.
Just had a couple of comments here. The only complaint I had in the past couple of months was the recertifying the cost on the dental assistants, and I think you took care of that. They were very appreciative. It was a minimum amount of cost, and I think it was a new policy that came down from the state. Is that correct?
That's right. They have required, after the situation that happened in Tulsa that we all were aware of, I think the spirit of that law that was passed was to be able to track where dental assistants have been, because they were trying to go back through the records and see who had worked at this office in the past, and there wasn't a true record of that. So, so what they've asked to do is that every dental assistant be registered with the state, regardless of whether they're certified or not. If they're working in a dental practice, they're registered. It's a $50 fee to register, and it's renewable every year, and they have to designate where they're at. So at any given time, if they need to go back and see if a dental assistant was working in a given place, they can find that. And yes, it was a contentious thing to have to require our employees to do that, and we absorbed the cost in our budget. All they had to do was they had to pay the fee up front and turn it in, and we reimbursed them. So we gave them plenty of time to turn that back in, and we just submitted all that information so that we could get that reimbursed.
They were very appreciative, Connie, so you and Dr. Jones, thank you very much. And thank you for bringing the unity amongst all the clinics there, because like you said, they were all acting individually. And I know you brought in a new philosophy with bringing you on board, and it's really working. I'm glad we have a plan in place now, and you're staying within the budget. I don't know why we haven't been doing that all along, so you're doing a good job.
We're actually under budget, but I want to show you some things here real quick, and then we can move on if we need to. But these are just some graphs of
Dr.
some-
Jones,
Yeah.
we've got a couple of more quick questions here. One from Councilor Fishenhoek and then Councilor Baker.
Most denials come from our income guidelines, and you've raised the I guess you've raised the minimum poverty level guidelines?
Right.
What'd you raise by?
To 300% of poverty, federal poverty level. So it's a chart that has how many live in the household, and there's a scale, and as long as they hit 300% of that number, then they're eligible for the cost program.
Glad to hear that. Okay, and you said you started going to schools in the 14 counties and Head Starts and doing sealants, fluorides, I guess?
Right. We've identified with education how many schools are in our 14 counties. We're looking at how we can access. Eventually, we're going to bring a program to you guys or to health to get a mobile unit that will actually travel to these schools year-round. And we've even, Dr. Speed and I having lunch today, she had informed me that one of the schools, Delonaghy, has a summer school put on the program. So we're even going to be able to do this through the summer.
Is it an income generator?
No. It's just beneficiary generated, so.
Okay. I'm kind of like Joe, I'm glad you started making the treatments in all the clinics the same, because we used to get a lot of complaints on that. And does dental have a billing department now?
We do, and can I show you this stuff, and this
Yes.
will kind of explain that?
Yes.
This is just a quick graph that shows how much production by month, and this shows the trend that we're going up. So we went back as far as 2011, October 2011. That's kind of when our electronic health record was becoming more accurate as more of our clinics got on. Previous to that, we had some clinics on it, some clinics off of it, so you were trying to pull information out of RPMS, trying to pull out of Intrex, and it's not very accurate. So that's about as far back as we can go to show the accuracy. This is just showing the production of how much it's changed. This was before we started implementing the changes in FY 2012. This was last year, and this is projected for this year, and this is how much production our clinics are putting together. Okay? This next one is showing patient visits. So again, we went back to October of 2011. This is showing the amount of visits and the trend going up. These spikes you see are from when we would start our Head Start and Sealant program every year. So you see this big spike where we were bringing kids in or going out to the clinics. This spike down was when we stopped everything for a few days and did an update on our electronic health record. In order to do that, we had to shut the clinics down, have all the things upgraded, everybody trained, then we came back on live. So we had a fall off here because every clinic was closed for about 3 days. And this is just a bar graph of that exact same thing, showing patient visits going up at each year for a year. And this is our projected amount for this year. This is probably the one that I'm most proud of, I guess, here. This is the revenue cycle that you had before we started changing it. So it was just kind of hobbling along down here at the bottom, and then right here is where we centralized dental billing, and we pulled 2 people out of finance, supplied 2 people, and we supplied 1. So we have a team of 3 people. They started working on it and seeing that we could change the processes. So one of the things we figured out is we did not have the right information coming from the clinics. So we halted everything, took those people out to the clinics, and we did training in every clinic. So you see this fall off because of the time that it took to do all the training and the backlog that gets stacked up. And then you saw this huge increase because now we're catching up. So we're gaining all the information at the clinic level that we need to gain. So each month, as we're gaining it, we're gaining that bigger and bigger. Than here you see it fall off because of the weather. And again, when you have 3 people and one person can't get there, or somebody takes vacation, 33 or 66% of your work staff's gone, it slows down your income quite a bit. But you can see there's a pretty big trend at what we're doing. I guess the last one is so here was your revenue before we put the training in place. Here's your revenue last year. From just these are actual dollars in the bank. These are actual money that's been deposited, and this is the projection for revenue this year. So that's the change that we're making and the things that we're doing to change what we're doing in order to be able to sustain our program a little better. Any questions on any of that?
Councilor Baker.
Thank you, Madam Chair. Back on the Crown policy that you're going to implement, will that be available to all Cherokee citizens, or do you have to reside within the nation?
No, it's going to be available to everyone, anyone that's eligible for our clinics. There's no subsidy coming in from any of our programs for that if we are able to implement it the way we want to implement it. There's a fee associated with it if you don't have insurance or a third-party payer. If you have either one of those things, then that fee could be negated by one of those parties. So other than that, and then that money will be used to replenish the program so that it's budget neutral for us.
Okay, good, thank you. Thank you, Madam Chair.
Counselor Buzzard?
Dr. Jones, is there a report, and you may already generate the report, how many dentures that we have paid per month per clinic? How many we denied per clinic?
We're
Be interested in seeing those numbers.
Yeah, we track that information. Yeah, I can get that information for you. The denials are pretty small. Usually, it's usually due to where someone lives. And I may be getting ahead of myself a little bit here, but we're looking at how we can internalize that and reduce that number too. But we haven't quite figured out how to do that
Are we
yet.
still letting people go out to people that make dentures and get them at our cost or your cost?
And that's basically how it works right now. You're referred out to a person that's on contract with us, and then they provide the service and do the dentures. We're looking at some, again, I'm kind of getting ahead of myself, but we're looking at internalizing that program, and if we can, we think we can treat twice as many people for the same money.
I know, I don't know who brought this up one time, but somebody brought up to make dentures, to set up a place to make dentures. You may not have had the time to leave and look at it.
It's basically more advantageous for us to let, even if we internalize it, to let a private entity do that for us.
I can imagine for the price that you're giving for it.
Right, it's just, there's so much equipment and stuff that goes along with that. It's cost effective to let someone do that.
It'd be interesting to see how many dentures are going on. Especially,
I can start.
Not about Jay, but I could just see.
Actually, if you look on the report that I provide to Ms. Davis, there is a place on there that shows how many dentures we send out each month. There's a line on there that actually, I put that in the report every month, and it'll tell how many patients were sent out for dentures.
Okay. Thank you.
Is there anything else?
Counselor Lay?
Any other questions?
The Dentrex system or program, was it here when you got here, or did you introduce it?
It was here. It's actually a, Dentrex is a private trademark name, I guess. It's the #1 program used for dentistry all over the nation. And Dentrex Enterprise is the government form of that. So it was already here. It was way behind, and the reason we shut down was because we had to update it. It was about 3 updates behind. So because of that, the billing package wasn't there to be utilized either. So a lot of these things, they update them and increase the information as you need it. As they identify that you're weak in some area, they may change the program a little bit to that stream.
And so with this system, you were able to see the numbers. It's just amazing. Will it be able to talk to the new EHR from medical, or is it just totally separate and you guys are going to run down your road, medical's going to run down their road?
We've been told in the meetings that there is an interface that is available. And I don't know how much I can say about it, but that was one of the questions that I asked, and that we were told it would work. So they're familiar with this program, Dentrex. It's not just an obscure program. Like I said, it's used nationally. So it's something that all companies are aware of.
Counselor Fisher-Hawk?
I'm going to go over some numbers with you that I asked offline, and Dr. Jones, correct me if I'm wrong. I've got your monthly report through January of your expenses because of the E&F report that I get every month. I'm looking at it, and I'm really speaking maybe to the council more than I am you, but like I said, correct me if I'm wrong. It shows that you're below in every expense in every category. Is that correct?
That's true. Yeah.
Okay. For 4 months for the end of January, he's hovering right around between 24 and 26% of his expenses instead of the third being used. I'm looking at a revenue report And on the income, you have, for your budget, you budgeted 900,000 in Medicaid, 600,000 insurance, for a total of 1.5. And right now, you're sitting at 1.2.
Right.
And these are actual numbers because they've been reconciled. He's already at 1.2 for the year, and I'm letting the tribal council know this because right now, he's on track to bring in over $3.5 million, and he only budgeted 1.5. So he's looking at overshooting his budget by $2 million, you all. And I think he deserves a hand for that.
Ask for some of it back to expand our services.
How much did you recover from unbilled Medicaid in your first year, Doc?
About $1 million, a little over $1 million. In Medicaid, we would have lost had we not identified it. It was services that we had done, and somehow in the system had gotten lost. So we've been going back, and we're still doing some of that because we're up through May of last year is where we're reconciled back to. Because 3 people are trying to work for 7 clinics and do the billing, go back and reconcile, look at the accounts, see if there was anything that was missed. So it's a lot of laborious process right now. I mean, it's very, very labor intensive for these ladies that are doing this. We're looking at it. We've been given to extend that staff by another person. So right now I've got another dental person on loan to them. So we've actually got 4 people working on it right now.
He was working in Dentrix, and there was no billing package. He had to go back and start over and create the wheel, everybody. His first year, there was $10 million in production when he started looking at the numbers, and less than 9% was billed, less than $900,000. And keep in mind, he done all of this with only 1 in 4 people having any kind of insurance that he could even bill to. I mean, he's done a remarkable job. I'm looking at sheets that he sent us, and I've seen some of them on Facebook and on the web, where he compared fiscal year 12 to 13, and in October, November, and December, he had over 2,000 more patient visits seen in our dental clinic. We're seeing 2,000 more people. He is applying his private practice model here at the nation, and he's making us money, seeing more people, and he is providing our people with more service. I don't know how you can bash him, but people seem to be doing it, and I'm proud of what you did. And I want people to know. I hope they go out and look at these graphs, and I would love for you to send these graphs to us electronically if you could, so we can get the news out. This would be a great story for the Phoenix.
Right.
There you go.
Thank you.
Any other comments? I've just got one short comment. I think you're doing a phenomenal job, and it amazes me that all this unpaid billing over there, sitting there in Medicaid, that no one saw it until you got there. So I think you're doing an amazing job. Go back to the beginning and bring forth all this money. And your private practice model is a model of hospitality and treating people just like you would if you were in private practice. I mean, not with the attitude that you have to come here. We want to treat people the finest, the best, just like if they were at a private practice place. So I think that's a really change in attitude, and I think that's what we need.
I have one other thing. Like I said, I had 2 guests with me. I didn't get to finish while ago. Dr. Speed's here, so if there's anybody or any programs in your community, she's here to answer questions or even to make us aware. So feel free to visit with her after the meeting's over. And then Dr. Andrews, who is the clinic director at Muskogee, he's been responsible for the biggest turnaround. He has the biggest clinic, and he's been responsible for the biggest turnaround by taking and implementing this model into place. So, and he's here to answer questions too. So if you have any specific questions that you'd like to talk to either one of them, we'll be around, and feel free to do that.
Councilor Fisher?
I do have one more thing to say. I was looking at the numbers, of dental visits and the numbers of the money broken down by each clinic, and I did ask him offline what happened at Sam Hyder, because there was less dental visits, there was less money. And I think it really stuck out when he said that is the one clinic that right away did not implement the changes I wanted made. And it's the one clinic that had the less visits, and it's the one clinic that went down in money.
Since then, we have implemented those changes, and we're moving forward. So it's being implemented now.
Thank you.
Yeah,
Yes.
say you increased your patient load by 2,000. How did you do that? What did you do? Who did you see?
It's about making more efficiency. We've got the chair, if the clinics are overstaffed with, then everybody's fighting over chair space. And, in a general dental practice, you usually have a minimum of 2 chairs to work out of. So you're able to, and by assigning assistants that work with you and learn how you work so that they can be more effective to get ready for you for each visit, get your stuff set up for each visit. Now we're able to instead of seeing 5 patients in that span, we can see 7. So we're increasing efficiency is what we're doing, making it more efficient by treating patients better, treating them with more hospitality, more customer service. We don't have as many no-shows. We don't have as many broken appointments because now people come in and they get in on their appointment time. They don't have to sit there for 2 hours waiting to be seen. We're seeing all of our emergencies every day. So those numbers should help fall off over time because we're not just treating the emergent needs, we're treating them and then they're seeing the value in coming back in for treatment. So there's a lot of things that go to play into this, but mainly it's efficiency.
Thank you, Madam Chair.
Well, we're very anxious for the new rebuilt old clinic to open down at Sallisaw, Redbird. Well, we're going to have 3 dentists down there, so we're so excited about that. And I've been hearing it's going to be just any day now. So.
Yeah, they're very excited to not be traveling anymore. They're all, every day I get an email, when is it going to be? So we're getting very close.
Would you ask the 2 doctors that are here with you to stand so we'll know who to talk to afterwards?
Dr. Speed and Dr. Andrews are back here today. Anything else?
Good report.
Thank you. Thank you. Moving on to old business, we've got discussion and possible action. Request Cherokee Nation Health Services Director Connie Davis initiate third-party post facto exit interviews for dental providers and provide feedback to the tribal council. Yes.
Madam Chair, I'm trying to work with them offline, and I know some of the stuff was covered today in his report, but I'll withdraw it at this time.
Okay, thank you.
And assuming I still get my meeting with everyone, so.
Thank you. Going on to new business.
Madam Chair, there
Yes.
was an item left off, and I put a note and then didn't get a chance to email you, but in the meeting minutes, which we've approved, we're supposed to have the 5% set-aside legislation that I put forward at last month's meeting, and it was promised to be on this agenda, and it's not. Do you know where that's at for the 5% set-aside amendments?
No, I don't. That must have been an oversight, but maybe, would that be more appropriate to be in rules or E&F?
Well, I know for months we had it on this agenda for another council person who then withdrew it. So I assume I would still have the appropriate jurisdiction, the same as any other council member in this.
So you want it restored for next month?
I would think it would need to be on.
Okay.
Yes.
Okay.
Just the same as somebody else would be given.
Shelley, would you make a note of that, please? Okay, going on to new business. A resolution directing Principal Chief and Executive Director of Cherokee Nation Health Services to begin negotiations with Indian Health Service to compact Claremore Indian Hospital for Cherokee Nation to take over the hospital, directing Cherokee Nation businesses to provide money to build a new hospital with added clinic space. Yes.
I'd like to call for the approval of this resolution.
I'm sorry,
Second.
excuse me,
Second.
point of order. I believe I am the person to get the floor first. Is that correct? As the
No.
person who brought it forward? As the sponsor, yes.
I drank my legislation before.
We already have a motion and a second.
Yes. We have a motion by Counselor Janice Taylor and a second by Counselor Lay.
I'd like to make a motion at this time that we table this indefinitely.
I second that motion.
I'll call for the question. All those in favor of
Wait,
canceling
call-
this?
Point of order.
Point of order, on a call for the question, it's not an immediate call. By Robert's Rules of Order, call for the question requires that 2/3 of the body agree with that. We have checked that out because this call for the question technique has been used so commonly. So anytime the Robert's Rules of Order say that anytime there is a call for the question that this body must take a vote and that 2/3 must agree to end debate at that time.
Her motion was to table indefinitely,
And I think we can take a vote on that.
so we need to vote on it. All those in favor of totaling this indefinitely, let it be known by saying aye.
Aye.
All those opposed?
Aye. Roll call,
Roll
please.
call.
This is yes to table and
Yes. Yes, it's to table this indefinitely.
Dick White,
No.
Curtis Snow,
no.
Denise Taylor,
I'm sorry, what?
This is to table this indefinitely.
Point of clarification, did you say yes was to table indefinitely?
Yes.
Yes, it's the table, okay.
Now, we were with Curtis. Curtis, what did you say?
I wanted to know, but you explained it, I want to vote yes.
Okay. Counselor Lake, Counselor Snell misunderstood what was said. I should have repeated it. Voting yes, we'll table it indefinitely. Is that what, clear? That's what he wants to vote, is yes.
Denise Taylor,
Okay, I do not want to table it. So it's a no.
Vote no.
Okay.
David Thornton,
Yes.
Victoria Vasquez,
Yes.
David Walkingstick.
Yes.
Kara Cowan Watts,
No.
Jack Baker.
No.
Harley Buzzard,
No.
Joe Byrd,
Yes.
Julia Coates,
No.
Jody Fishinghot.
yes.
Janelle Fulbright,
Yes.
Tom Garvin. No. Frankie Hargis,
Yes.
China Gloria Jordan,
Yes.
Lee Keener.
No.
Nine yes and 8 no.
So it's tabled indefinitely. Next is announcements. The next meeting is tentatively scheduled for Monday, April the 14th at 1 p.m.
Second.
Motion has been made and seconded to adjourn.
10
All in
minutes.
favor of adjournment?
Aye.
Aye.
10
This meeting
minutes.
is adjourned.